My name is Erica Bleakley. I'm an occupational therapist from Australia, and I am really delighted to be chairing this session today in my role as the chair of the World Rehab Alliance's emergencies workstream. Today, we have a truly impressive panel of experts to discuss their experiences and perspectives on providing rehabilitation in conflict. Our panel are all either living and working in conflict-affected areas or are regularly working in these environments. And they have very contemporary and current tips to share and advice for our colleagues who are also working in conflict-affected environments. So I'm just going to introduce our panelists now, and then we'll get into our discussion. So firstly, we have Fatima Nasser Adine, who is representing Humanity and Inclusion. Fatima is a Lebanese physical therapist holding a master's degree in public health and physical education. She's been working in the humanitarian field for over 13 years, primarily in emergency contexts across Lebanon, Syria, Iraq, Yemen, Jordan, and the Central African Republic and the Democratic Republic of Congo and Haiti. She currently works as a rehabilitation specialist for the Palestine Mission. Next, we have Verena Kreiliger Young, who is representing the International Committee of the Red Cross, also known as the ICRC. She's currently based in Amman, Jordan, but she trained in Switzerland and completed postgraduate studies in New Zealand, where she now resides. She has over 6 years' experience at the ICRC, including over 2 years in her current role with the hospital team. And she's worked extensively in diverse contexts across the Eastern Mediterranean region and other conflict-affected areas where ICRC operates. She brings a wealth of expertise across the entire continuum of care, from early rehabilitation to reintegration. Her experience expands both the humanitarian sector and New Zealand's governmental healthcare system and reflects a deep commitment to improving patient outcomes in challenging environments. Next, we have Firas Swerjo. So Firas is a physiotherapy activity manager with Médecins Sans Frontières, or MSF, and he has 11 years of experience working in rehabilitation in emergency and conflict areas. He is currently based in Gaza and has worked across multiple conflicts, providing rehabilitation for patients with severe injuries, including burns, amputations, and complex trauma, always in close collaboration with multidisciplinary teams. Firas has contributed to early rehabilitation for amputees during his work with MSF in Ukraine. And he focuses on clinical supervision, capacity building, and developing practical rehabilitation approaches in resource-limited and high-pressure environments. He is particularly interested in early rehabilitation in emergencies and in sharing field-based strategies to prevent long-term disability and improve functional outcomes. Next, we have Dr. Shal Khalif. Dr. Khalif is a doctor of physiotherapy with a master's degree and over 15 years of experience in clinical rehabilitation, program coordination, and humanitarian medical response. He is currently the head of the Department of Physical Therapy at the Lebanese German University and has served as the head of the Rehabilitation Center at Hospital Kortbawi. Hopefully I said that correctly, Doctor. He is also works as a physiotherapy at LAU St. John Hospital, and he's actively involved in emergency response as part of the search and rescue team at the Lebanese Civil Defense and serves as the official representative of Pompiers Sans Frontières, which is a French NGO. Beyond his clinical and volunteer work, Dr. Khalif is passionate about education and mentorship, guiding physiotherapy students and young professionals in developing their skills and professional growth. He specializes in coordinating multidisciplinary teams and designing training programs that integrate academic knowledge with practical experience, ensuring excellence in both patient care and professional development. And lastly, but absolutely not least, we have Amani Alser, who is representing the WHO in Gaza. Amani is a physiotherapy and rehabilitation officer with the WH Office for the Occupied Palestinian Territory and the Gaza Rehabilitation Task Force Coordinator. She's working very hard to strengthen rehabilitation services in emergency contexts, and she's passionate about improving access to care for people with injuries and persons with disabilities and integrating data-driven approaches to enhance the quality, coordination, and impact of rehabilitation services. I think you can all agree, like I said earlier, it's a very impressive panel of people with highly relevant experience. So I'm delighted to be able to get us started in our discussion. So firstly, I'm going to go to Dr. Shal. So Dr. Shal, Lebanon is one of the many countries, unfortunately, in the region affected by conflict at the moment. Can you describe for us some of the main challenges when you're delivering rehabilitation services in these areas?
Good evening, everyone. I will give a brief about our work in Lebanon with the Lebanese Order of Physical Therapists. 2 years ago, for the first war in 2024, the Lebanese Order of Physical Therapists create a crisis cell. And with this crisis cell, we took many volunteers of Lebanese physical therapists all over the country. We know that Lebanon, it's not a big country, but we can say that many of us know each other. But in the crisis, in the war of 2024 or this war now, there is some region who are infected more than the others. So this is the main problem that we have, because we have a problem of fragmentation of the healthcare system. I give an example in the south or in the south or in the Bekaa. It's not like in the other region, like in the north or in the middle of Kasserwan or Beirut. So this fragmentation of healthcare system can bring many problems for hospitals and private clinics also, and center of rehabilitation for physical therapists. The second problem is the infrastructure damage. So if we need to help the displaced people, there is a big problem here because we can't go all over the country. So the little teams of the LOPT who create them are volunteers. In many regions, there is a team of physical therapists, volunteers, who can help in prior the displaced people. For example, I give a patient who go to a clinic in the south, and now he can't go there because or the clinic didn't exist anymore, or the physical therapist is also displaced, or maybe for a center or hospital. So this person, when he will go another region, we can help him with this group of physical therapists or volunteers of physical therapists. Then the second problem also, there is a high patient demand. There is high patient demand. It increased the number of war injured and people with chronic disabilities. This is two high problem: the chronic disabilities and the new injured people. Like for example, the attack of yesterday in Beirut, we have a lot of injured people, and we called for volunteers to help about this in early rehabilitation or to help in wounds also, not just for rehabilitation. Another problem we called about it, it's economic problem, because the people can't afford to pay the session, though, and the volunteers can help. They can help for the sessions, but they can't help for every day, because they work also with their normal patients with them, and to add another region the another big numbers. This is mainly one of the problem, and also the big one is the security. Is the security problem, because we can't know the. It's not by the region; it's all over the country.
Mm.
So we help as we can. We
Mm.
continue to launch our crisis cell, but we need also other helps, because also we have the material. We have a lack of problem with the materials. We have a lack of problem with centers. Some of rehabilitation are made in shelters. We go to shelters to see shelters are maybe camps or mainly schools. So when we go there, we can do the real session, the physical therapy session for this patient. We do the as consultant. If we have a hip problem, injured, we called for to have a bed, to have crutches, to have splints. Dogs. It's the main problem that we have, but we are working all over the country about this.
Mm. Thank you, Dr. Schalt. Very familiar challenges to things that I think we probably will also hear from Faras and Amani and Fatima about, and Verena about the challenges that they've been experiencing. I would like to just open up to see if anyone of the other panelists would like to add to the challenges experienced by in delivering rehabilitation in conflict-affected settings.
So I will add one thing
Oh,
that
sorry, Charles.
sorry, no, I will add one thing about our colleagues and the panels, because in the beginning of the 24 war, when we did the crisis cell, we did it with President Saidi Sissin and Dr. Mike Landry. We tried about it, and we trained the physical therapists in all the region, the volunteers, with HI or ICRC or other Interburn and other to make the early rehabilitation, because it wasn't something familiar in Lebanon
Mm.
to have the early rehabilitation. We have a very good physical therapist and a very good healthcare system about this, but the early rehabilitation like this, we didn't have it as physical therapists. So we made all over 1 year and a half, many of these trainings, specific trainings, to have a bigger numbers of volunteers physical therapists due to LOPT to work all over the Lebanon and aid the maximum of displaced people and to help them.
That's really interesting, Charles, because that's quite a rapid increase or rapid change to the approach in providing rehabilitation care in quite a short period of time. So quite impressive that you guys have managed to, instigate early rehabilitation in a setting where that wasn't there already. Other panelists, would you like to add anything to the discussion about challenges of delivering rehab services in these environments? Please, Verena, go ahead.
Thank you very much, Charles. I think it just highlighted a little bit what you said at the end. Most of our physiotherapy education is not geared for conflict. And in conflict, we see quite different and quite specific, more serious injuries. So I really commend you in Lebanon to take the initiative when you felt the heat was coming up and you needed to prepare your workforce. And I think that is a lesson which can be learned from all of us and from all other contexts as well, because things change quite rapidly and the demands are quite specific in particularly in conflict and particularly in the current conflict. Thank you.
Mm. And I think it's also a nice example of, we don't ever want to be in these situations, but I think they can often represent an opportunity or a catalyst for system strengthening. So again, congratulations to LOPT and your colleagues. Amani, Faras or Fatima, would you like to join in on this discussion, or we can move to the next question?
I just want to add one point, Erika, and
Yes,
related to
please,
the
Amani.
challenges. Yes, the challenges conflict area. In Gaza specifically, we have a massive number of the spinal cord injury and traumatic brain injury, plus the massive number of the newly amputation cases. The Due to very limited of the bed capacities and the massive mass casualty cases, when we saw them in a daily basis, we lost the quality and the specialized rehabilitation with high quality for those cases, especially when we talk about the spinal cord injured with Asia A and Asia B with their very complex and critical cases. Unfortunately, this leads to increase the number of cases with permanent disabilities, and this is one of the red flag for all the our activities across the all the Gaza Strip. The second one, it's a really related to Gaza context more than any context in the world. It's the severe restriction of the access of the assisted product to be entered to Gaza. That's because Erica, they are considered as dual use, so we're not able to enter them. And it's really affect the reintegration and the psychosocial status of the injured. That's because they feel like they are isolated and they are not able to join with the community to their activities anymore, especially when we talk about the patient with the hemiplegia, paraplegia, and so on. Thank you, Erica, and over to you.
Thanks, Amani. Over to you for us. Please go ahead.
I think also working in such difficulties like this, our physiotherapists should be prepared for a mass casualties. So it's better to have a plan, to have a training for all health workers that they have to be involved in the triage system at the point of the mass casualty. So this point we are taking in Gaza in advance. We trained our team, even physiotherapists, occupational therapists, to be a part of the triage system during the mass casualties. And we see this practically on the ground near to Gaza Clinic Center of Gaza City when a big shelling happened 20 meters away just from the clinic. And at that point, we directly in 2 minutes convert the clinic to the triage system with the color coding. And all the physiotherapists was involved on this. It was in the primary, not in advanced, but at least they do something on the first step from first aid, segregate the patients, and make the color coding zone. And that was very helpful to transfer the injured directly with the ambulances to the nearest hospital in a very short period of time. And that really saved a lot of lives at that incident. So from this experience, I'm really recommended just to think about and anywhere in the world, if you expect massive mass casualties, be prepared for it. Even with the physiotherapists, they can understand. They are very intelligent and they can take this rule.
Yeah, thank you for us. That's something that I definitely agree with. I think that there's been a tendency to have rehabilitation professionals kept at arm's length from things like mass casualty triage, whereas I think we can all agree that we're very capable of doing that initial sieving process at least, and it's a way of contributing to the overall health response. So thank you for raising that. Fatima, I think you had your hand up. Did you want to add something?
Yeah, I mean, I want just to add just one point because like the scenarios sometimes like is like the main point who like orientate the intervention. So in Lebanon case, like yes, there was a part of induction training and what etc. of capacity buildings, and in any other country like Syria and all conflicts country, what was missing the mainly point is about the inpatient departments, or like when you have a big destruction of health facilities, the small health facility became the hospitals, but the rehabilitation services became also the like third party service. So sometimes like they left behind that, yeah, we have to work in shelter, community, run behind, but in patient hospitals, the departments, or in the primary health care, who became the first aid care, so who became a hospital sometimes because of the huge destruction, like also the field hospital itself, the rehabilitation became the last like service could be taken into consideration, or like not left behind, but the main point of early rehab or people to like find them at that place. So my recommendation in any conflict, like to advocate, even when you know the context is volatile, to the rehabilitation professional to be part of the EMT. Yes, in the papers is written are part in the EMT, but in the reality, especially in Middle East, like they are not part of the EMT. There is different points like highlighted by Dr. Charles, can be economical side, can be limitation of assistive technology side, like because rehab is very linked and is another way of advocacy as well for assistive technology to be part of response. But in the same time, like to be spontaneous as a professionals, like all professionals, like I would say certificate of physiotherapist, whatever the association in our country, to advocate, to like to included in the response from the first day, like because sometimes we speak about country even very developed, whenever the conflict arrive, so rehabilitation is not priority. Just sometimes the scenario like focus on shelters, displacement, big hospitals, but I mean the small PHC who became hospitals, or the rehabilitation services like should be as much as inclusive even in access part. This is my point. Thank you.
Absolutely. Yeah, completely agree. And I think we could probably do a whole other session on getting your advice about how to make sure we do get that integration happening, because I think that I think it's a shame that the health system are missing out on having rehabilitation at the earliest point of a patient's care, because they don't realize what they're missing out on, and what, how you can support the functioning of the health system. I'm going to move on to our next question for us. This one's coming to you. So working in conflict can be exceedingly stressful, and especially when you are from the affected area. How do you take care of yourself, and do you have any tips? I hope that we can assume that you are taking care of yourself, but do you have any tips for our colleagues online who are finding themselves in similar situations? Thank you.
To be honest, this is a fact. It's really a fact that people are working under stress, and especially when they are living in the same condition, in the same conflict area. Working and living in the same condition area are duplicate the stress. So I would like to answer this question in two parts. First part, how to take care of yourself when you go back home, and the second part during your work. So it's something different, and the organization also can help to jump above the obstacles with many of coordinations and support. So let's start with the living conditions. Most of the workers, the physiotherapists, occupational therapists, any health worker, when he go back home, he's living in shelter. It's not looks like a bunker. It's shelter above the ground, and it could be uh, beside any target and cause injury on the family, on the colleagues. The organization, they provide shelters for the staff and their families on special places, and thanks God they make it coordinated as deconflicted area, and this cause some decrease the stress from the staff, as at least they are feeling safe when they are going back home, living with families. And they provide also very big support with the mental health and psychosocial colleagues. They make some events. They advise people just to play with the kids, just to make some enjoyment for them. Try together when you eat, make meals together, and mainly it was the dinner. because most of us going back late to the shelter. So we gather to take a dinner. We discuss our fears. We try to calm each other. So the colleagues working together and also living together give some positivities to decrease the stress. With also some events, they do it to make some plays, some games for the football, enjoy with the kids. That events also cause very good factor to decrease the stress. And the transportation was provided between the shelter and the hospital or the clinic that we are working in, and that movement was flagged by the organization flag with a special coordination for the pathway of the movement. Also feeling comfortable to go work and come back with a coordinated movement, it was also decreased the stress a lot. When we go to the work environment, that was more stressful than the shelter place because you face the massive injuries face by face. You work by them. And the part was from the management to facilitate how to decrease the stress for the workers. First thing that we do, we didn't put a lot of pressure for people to work with some cases they don't want, how they fear. So we move them to a second place that can help in a less activity and a less pressure. And we do rotation. The good thing that giving a good performance and tolerate much pressure is to rotate the staff, not keeping them on the same place for a long period. So we try to rotate in daily base. So physiotherapist is today working as a triage. He can just segregate the patients. They ask them to go to the department or to go to the nursing room or have to go to the ER directly. They can work today on the triage and the second day beside the nurses on the dressing room and another day on the rehabilitation hall or rehabilitation department. So this rotation facing a different type of patients, not always with a complex case. Today with the wounded, injured people, tomorrow with the closed wound, with more advices for more than hand working. So it's decrease the stress. And we ask them also to try to take several breaks, not to continue work for 7 hours or 8 hours continuously without taking some break. Take a breath. After each patient, you can take 5 minutes. Even if you are a smoker, go outside, take a cigarette and come back. So this giving some space to them to express and decrease the stress itself. Also, we ask them, if you get tired, don't shy to say. Just express yourself. Let us know that you are tired on this moment. You can stop. We can send another colleague to help you. If you feel too much pressure, go and consult our mental health team. They also can support you. So with these steps, it's keep a long period of performance for the people, even with the high stress environment. And also we ask them to try to call the family on the shelter. Go outside, just pick up the phone, try to call your wife, try to call your kids. If they want something, if you find something here you want to buy, go take it with you when we are going back to home. We can gather also at the end of the day to discuss a difficult case. when we see a very massive or a big challenge with the patients, at the end of the day, we gather all the therapists together to raise the issue. How do you feel? What do you think the plan of treatment should be? We ask each one just to be focused, just to be sometimes with this a lot of cases we lost our focus, we lost our concentration. So when we ask each other, sometimes I forget something, the colleague they can remember. So when we collect information from each other, we decrease the stress and we get the most benefit plan for the patients. That really was on the ground, applied on the field, on the clinics. And also we can change the place. Today we are working, you're working in the hospital, tomorrow go to the outpatient clinic, you can have your work there. We know it is could affect the continuity of the care for each patient, as we also target to work as a patient coach. But on this mass casualties, massive, we need to accept that we cannot help everyone. This is a fact. And every moment we remember everyone. You do your best. We know you will do your best, but you have to accept that sometimes we will lose someone. Sometimes we could not help everyone at the same time. So do your best and be proud of yourself. Make yourself proud of what the small things that you are doing. It's really valuable. It's really we need it on this mass that happens around us. So on this way, we try to decrease the stress.
Thank you for us. It sounds like you have a really lovely system and process in place. Just to acknowledge again the incredibly challenging environment that you're working in. I'm interested to know from you whether prior to this current conflict or escalation of the conflict in Gaza, was it common that your staff would engage with mental health support services, or is this something that it's kind of new for your staff to get used to having access to and taking advantage of?
It is a common. The mental health is a solid part. It's kind of a column on our organization, and they are support both. We have a team supporting the colleagues, and they are taking care of them, and then another team supporting the patients, and they are taking care of them. So this system is presented before the war, but not in as big as what we have now. After the war, they increased the activity. They engaged more in every moment, and even they are engaged in the patient sessions. When we feel the patients had a pain, they integrate for pain management. They try to distract the patient. They try to make some stories, especially with the kids, with the children. We always, as a physiotherapists, we call them just to help us in the sessions, and they are engaged.
Great. Sounds, yeah, very great. Very interesting. I'm conscious of time, so I'm going to ask if any of the other panelists have any advice or tips they'd like to share around looking after yourselves in these environments. Please, any of you, if you'd like to comment. No? That's okay. I think we will thank you so much for us. I think that we might have some more questions from the audience a bit later. So we'll head on to the next question now, and then we can come back to you, I think, or the rest of the panel on this topic. Fatima, you're up next. And the question we have for you are, what are the skills you think rehabilitation professionals should have to work effectively in conflict? This is a question that comes up a lot around rehab in emergencies. So I'm very interested to hear your perspective. Thank you.
Yeah. To answer to that question, I want to put this discussion in a scenario, in the setting itself for the emergency context. So I will use some photos to explain the reality, to make like more clear my point of view related to the skills. And now I will be sharing my screen. If all good, if you can see my screen.
Yes, perfect. Thank you.
Okay. So first, when we speak about skills for professional rehabilitations, we know all that any professional rehabilitation has basic skills getting in during its education. But in conflict scenario, in conflict setting, this skills became different. Beyond the clinical skills and expertise, the professional need to combine technical, practical, and interpersonal skills. I will speak more about more example from the emergency field perspective. If we look at the photo, we speak about the environment itself. Like when we have a rehab center in very calm setting, and a rehab center initiate or like rehab unit initiating in very conflict area. And I could confirm for you this is the best options you could have in Gaza at the moment. So speaking about the skills, is already mentioned by different panels that early rehabilitation. But what does that mean, early rehabilitation? Like the physiotherapist has to be ready and have strong skills and knowing that if I don't intervene at the moment now, the person will have long-term disability. But intervening in such condition need also to have skills on how to assess safety and security awareness. If we look at also the setting, some skills need to have it advanced, like the bandage or like taking care of stamp management. In traditional rehabilitation settings or in the non-ward, non-conflict setting, we can have all the equipment, all the measures. But in emergency setting, we have to make sure that also every professional has the IPC, like the infection protection control measures, because he could work outside, he could work with the patient with all conditions that are not respecting any measures, but he should respect them for his safety and the patient's safety. In parallel of that, the contingent will not help a lot because we have limitation of resources and limitation of equipment. So he need to be having adaptation and multidisciplinary approach, because like rehabilitation in conflict cannot be only physical therapist. He should have with a patient itself, with its caregiver for the continuity and care, and with other professionals. I would like to highlight at this moment, like when we speak about rehabilitation and conflict, every professional need to know that his complementary and multidisciplinary approach with other member of rehab professionals, and like could be occupational therapist, a speech therapist, and especially integrated with mental health and psychosocial support. For that, he need to have a lot of ability on adaptation and problem solving, because he might like see cases didn't see before, he might work in a condition didn't work before, and he might be in a situation that cannot be more affected than other situation, like access and more difficulty to see. I would like to also speak about one part not related to any slide of it, just to remember, because yeah, to remember like 1 minute, sorry, to remember that like besides that we are physical therapists, we are a human being, and besides we are working as physical therapists, we work also with people. The conflict are not giving them only loss of function, but maybe loss of family, loss of life, loss of memories. So in that case, the physical therapist has to have a strong skills and empathy, resilience, and ethical emotional adaptation. So he had to communicate well. He had to know that he's in the scenario a professional, to be all the time putting himself aside of the patient, but sure with a neutral condition, because he's one of the hand taking the patient outside to go back to his social participation. So this all is just to explain and to give last message. When we work in conflict, the skills are meant to have strong clinical skills in like early rehabilitation, but besides that, working with expertise on adaptation, flexibility, and resilience, and ethical and emotional perspective under pressure. This is what I can resume from different perspective, that physical therapist has to imagine the scenario and being ready for any conditions they are working in.
Thank you, Fatima. And I think that what you've just mentioned is probably is applicable for all professions working in conflict environments. So definitely, we know that physical therapists are usually outnumber everyone else. But, you know, I think the same skills and requirements apply for occupational therapists, prosthetists, orthotists, physical rehabilitation, physicians. I'm wondering if we specifically talk about occupational therapy and prosthetics and orthotics, and I'm throwing you a little bit in the deep end with this question because I didn't prepare you for it, but I'm wondering, can you give us some of your observations on maybe how we can start with occupational therapy. How has their sort of focus or practice changed since the onset of the conflict, and now that they're working in a very acute emergency? Are they seeing different patients? Are they prioritizing their treatments?
Yeah, it becomes part of the comprehensive approach. It becomes part of the initial assessment part. Like when we go, if we take an example about how to assess the patient at the moment, we stop assessing the clinical, even in the form, like the clinical paper. We speak about one part of trauma like scores, and we speak about functional scores. So automatically functional scores like orientate us to the occupational therapist. I am not saying like physical therapists are not keen on functional, or the opposite, like occupational therapists cannot focus. But we need to have a multidisciplinary approach with a lot of cases, with variety of cases. Unfortunately, cases who having loss of function could be permanent and could be temporary. Like we need like the perspective of case management, like multidisciplinary approach. And the occupational therapist, through especially for Gaza response, what I am talking now, they have a very big added value in adaptation, in motor skills, and in accessibility perspective. Unfortunately, before, the accessibility perspective was seeing only regarding like construction and things. It's not like focusing what occupational therapist or functional rehab professional can do it. So they are more like involved. And I can do an example from other context. I mean, recently I worked. We have a big, like we have a small project in Haiti. I know it's not the same as the construction of this conflict, but all conflict having their speciality. But we have like a project about functional empowerment, and we were also working only with people like affected by the crisis, but they lost everything and their function, not because of injury, because of other like ability to do, like they start not are to able like to like old age people not to walk or to talk, etc. So we were like discussing what's more like suitable to have it in functional approach. So we were doing common group sessions, including occupational therapist and physical therapist and psychologist. And it was only objective for us to come up with social participation, like to start like a daily life activity with the manual exercise. So we found out like sometimes we just focus on big component of rehabilitation, when there is more, like when there is functional component, can even add more impact. Why I am giving this example? For this example, for me, is a comprehensive approach, and also each professional has his role in conflict, but cannot be standalone. This is what's different from the you can see very good rehab center in very calm context, but you can see people go directly to the room of physiotherapist or to the room of occupational therapist without this even in conflict. Is, I will not say a positive way, but we learned that like working together, how it become for one functional objective. So this is really seen on the field itself.
Thank you so much. That was a brilliant example. We're going to move on to the next question now. And so we are welcoming back Amani. Amani, we'd like to hear from you about what are the most common challenges you've encountered working in conflict, and how have you been working around these to deliver rehab services?
Thank you so much, Erica, and thank you so much for Carlos for the first speech and the webinar. Maybe he's sum up all the, let's say, common challenges in the complex settings, from the displacement order, the continuance of displacement, the severe shortage of the assistive product, and the supply for the cases. We can also say one of the common challenges is the limited access for the transportation the cases from their home to the clinic and back. So this is a very common challenges we're faced in the any conflict area. I would like to highlight three more challenges. The first one is the, as I mentioned before, is the very limited of the.
I think we might have lost Amani for the moment. Just looks like her power might have dropped out for a minute. I'll ask some of the other. Oh, Amani, you're back.
I lost the electricity.
Yes, no, we
So,
noticed your lights went out, but please continue. Thank you.
I have to turn off my video, then continue by using this speaker.
Sure, no problems.
So again, we can talk about the first one is the harsh condition and the catastrophic condition the people are in Gaza live in. So most of the people right now are living in tents and they are living in very harsh condition. So unfortunately, based on the very limited of the bed capacities in the specialized rehabilitation hospital and also in the mass casualty and tertiary hospital, they had to early discharge the cases. So in Gaza, we established something of long stay unit or the step down unit. The concept of the step down unit or the long stay unit is the like intermediate place before discharge the cases to the community again in the tent in very harsh condition, to have at least a place with wound care, with psychosocial support, with physiotherapy services as a comprehensive services, to not left those cases suddenly behind, and to have a proper home program before they left them to the community again. This is really support us in decreased the permanent disabilities for the cases, especially the cases with major complex injuries in limb, and also in the cases with the spinal cord injury and traumatic brain injury. The second point from my side is I would like to talk about the I am very glad and delighted to share the AP tracker, the assistive product tracker system. It's a unified system we're established in across the Gaza Strip. This is one of the something I'm really proud to talk about them. That's because we gather all the organization are working in the rehabilitation sector to enter the data of the assistive product and to avoid duplication for all the cases across the Gaza Strip. As everyone is know, the Gaza is very يعني critical in the access of this assistive product, and all of them are considered as a dual use.
Amani, we're just losing you a little bit. I'm just wondering if your connection's become unstable. I think she might have dropped off for the minute. So I won't keep talking on her behalf. Hopefully she'll come back to finish telling us about the tracker, because that is a great piece of work. I might actually ask one of our other colleagues who have been working in Gaza to maybe talk about the tracker from their perspective, because I do think it's a really interesting and successful solution to a big problem. I might go to you for us, if that's okay. If you could maybe tell us what the problem was that the tracker has solved, that would be great.
The idea of the tracker is initiated by the WHO because they are the main importer for the assistive devices to Gaza. As we are in the conflict, we are facing a very big shortage on the assistive device. Sometimes we try to manufacture it locally from what's available in between our hands. And the idea of the tracker is to track where is these devices distributed, because some patients are sorry to say that, but they are doing like a shopping, coming to MSF to take auxiliary crutches, and in the second day or on the same day they are going to HI to take another one, just to keep it afraid that someday I will lost, so I have a spare. So the idea was to use the patient ID on a centralized tracker filled by the all organizations on a direct link on a website controlled by WHO. So when the patients reach to MSF clinic and we donate for him, and for example, auxiliary crutches, we just register only the ID number and the assistive device he received, and the date, and the organization donate for him the device. So if he go to another facility to take another one and duplicate the quantity he take, they will check before second donation. So before each donation, we check on the tracker the ID number of the patient, so we can understand what he get recently or he didn't get, and that make another global overview for the patient's needs. So some patients need, in addition to the assistive device, some hygiene materials, like elderly people. So some organization they can donate, and another they can donate the rest of the thing. So this is giving us a better idea about the patient's need and what he received and from which organization. That affect the quantity available with the organization's stock. So if MSF imports something, they can serve another patients, and this make a very big rationalized distribution for the benefit of the patients themselves. So the tracker today, we just go to the second step of developing that tracker to have a dashboard for the organization. They can take some statistics, some visualized graphs to know last month how many donation they did and which kind of donation they make. So this really helped us on this very difficult condition, and it's controlled much better than before the distribution. This is in general.
Thank you for us. That's a great overview. And I just, really can acknowledge the work of Amani and Claire O'Reilly and the entire rehab task force in Gaza for, developing it, but also really coming together quite cohesively to adopt that system. Amani, I am going to keep moving just in the interest of time. I hope you're back with us for your question a little bit later. But now I'm going to go to Verena from the ICRC. Can you please tell us a little bit about humanitarian principles and why they are so important in conflict? I think these conflicts we've seen more and more conversation about humanitarian principles and whether or not they're being applied. And I think for this group, it would be very interesting for us to understand a bit more about them. And who better but someone from the ICRC?
Thank you very much, Erika. So the humanitarian law was designed, as you all know, after the Second World War to protect civilians and others who are not or no longer involved in conflict and are not taking part in the hostilities. This includes all of us, humanitarian workers, and all of those who provide rehabilitation services in conflict areas. So there are three very basic principles, and for those who were at last week's session, Pete already touched on those. So these three basic principles are the backbone for the international humanitarian law. The first principle is that humanity forbids the infliction of all suffering, injury, or destruction not necessary to achieve the legitimate purpose of the conflict. The second principle is the principle of military necessity, to say, permitting only that degree of kind of force required to achieve the legitimate purpose of a conflict. The third principle is that the parties to the conflict must at all times distinguish between civilians and combatants in order to spare civilian populations and civilian property. Attacks may be made solely against military objectives. So these humanitarian principles are very important so we can do our work. And we can do our work in the humanitarian setting to provide rehabilitation for populations afflicted by conflict and to reduce the suffering of those affected by conflict, and especially of the vulnerable people populations. As we know, as we've recently have just heard when the Undersecretary General of Humanitarian Affairs in Emergency and Relief Coordination spoke at the World Health, at the World Assembly, over the last 3 years, over 1,000 humanitarian workers have been killed in the last 3 years. So obviously we see that these very important principles who underpin our work are not necessarily adhered to. So just recently, the ICRC president, you mentioned that who is better to speak about it as somebody from the ICRC. So our president has just stated, and I quote, "I urgently call on all parties to spare civilians and civilian objects in military operations. It is their obligation under international humanitarian law. Indiscriminate warfare is indefensible and incompatible with law. States must respect and ensure respect for the rules of war in both what they are saying and what they are doing. The world cannot succumb to a political culture of prioritization, death over life." And I think, I know this is all a little bit heavy on the law, but I think the last sentence is what drives all of us to work for this better cause, either outside of the conflict or inside of the conflict. And I just want to acknowledge here all of our workforce who is currently very personally affected in that. So this is a very, very important issue for all of us so we can do our work. We have heard the struggles there, particularly in Gaza, with the reduced entry of equipment and the severe shortages. So we should not give up the hope that these things will improve and that as a humanity, we can stand up and say what we want to do. And I think this webinar, coming together as a profession or as professionals, is a very good example of this light in times who are quite dark, to be honest. So thank you very much for all of those who are interested and who are participating from the region of the conflict, but also from those all around the world. Thank you for being part of it.
Thank you, Verena. And it's a complicated issue, but also I think there's a lot of actual simplicity in it as well when you read the words as they were written. I think this is a nice time to bring in a question from our participants. We've had a couple of questions about how, and I'm opening this up to everyone in the panel as well as you, Verena, but how can the global community or the global humanitarian community support our colleagues working in conflict affected areas, and how can we sort of leverage the goodwill that we see in this setting and that we see in a lot of different settings? How can we leverage that to advocate for and optimize the delivery of rehabilitation in the region? Verena, I might go to you first and then open it up to the others.
Yeah, thank you very much. So I think there is several layers of work we can do. First of all, as an individual, you can donate to those organizations who are also hamstrung by financial constraints to deliver the care they can. And I think that is a reasonable thing to ask for, because we all know that the funding has been cut across the board to all of us, and we're all restrained. So that is something which all of us can do on an individual level, those who have the capacity, of course. Then the other is the moral support, to stand with all of us, to stand together as a profession and say, what do we want to do? It's also providing opportunities, resources for those in conflict areas. And Amani said something at the beginning. She talked about data-driven rehabilitation. And I think that is one thing which is very close to my heart and very important. And I think those who are not actually inside the conflict can support those who are working in conflict with providing support for that data-driven rehabilitation, and to support with research opportunities so we have more evidence for what we're actually doing. I might hand over to somebody else at this point.
Fatima, please go ahead.
Yeah, I mean, first, like to consider rehabilitation part of any interventions they are doing in health sector, because most of the time, like when they call for any project, like it's mentioned in like protection, but I mean they don't consider rehabilitation part of health protection, which is like preventing all long-term disability. And speaking about data, we try as HI, mean, to do a lot of advocacy to include like the disability question in the data, but not only about like disability for any to take only person with disability, but because when we talk about advocacy, we just recognize, yes, WHO interval is 50% now on the world, like people with disability. But when we go to conflict, we don't have even the data to advocate or to say like, yes, this is the range that before this one, but the number at like with the time, like the percentage is behind, like is behind even 25%, unfortunately. So even like asking like humanitarian actors and the community uh, to think about the need assessment itself or the need response for the whole components, because this number is not like by coincidence. This number because there is also service missing, which is rehabilitation. So this is one big part, and me, I use the opportunity also to advocate for like taking people with disability in all sectors, inclusive approach, because like also prevent to have more and more need and no response on it.
Thank you. Amani, we'll come to you now.
Thank you so much, Erica. I would like to share, and thank you, Verena, for your speech, and especially for data driven. I would like to share our experiences. This is an ICRC mainly experience, and we are supporting and we're coordinating. ICRC right now, they are supporting Ministry of Health in collecting the detailed data of the amputation cases and spinal cord injury and traumatic brain injury cases, with the very, very, very detailed assessment, including the type of the amputation and the need of the supervision, the type of the حتى even the type type of the artificial limbs are amputated. So we can have an evidence-based planning and a pragmatic thinking and a strategic planning for the massive around 6,500 patients with amputation across the Gaza Strip. So that's because I really stress, I'm really interested to have an evidence-based pragmatic thinking and strategic planning for the conflict region to have a more sustainable health system and effective impact for them. Thank you so much again, Verena, and over to you, Erica.
Thanks, Amani. And I think that, I mean, ensuring that we are, if our colleagues in conflicted affected areas are going to the trouble to actually do a lot of data collection and analysis, that's something we can do as a global community, is really take that evidence and take that, that information forward and amplify it to the people that need to see it, and continue to advocate for that. Amani, I'm just going to quickly, did you want to add something to that? Or is your hand still up from before?
Old hand.
Old hand, old hand. Dr. Charles, I saw that you sat up quite promptly when we were talking about how the global community can support. Did you have something you wanted to add there?
I guess in Lebanon, I can send a message to physical therapists to said if they want to be volunteers in the crisis cell or in the region, they can contact me or contact the LOPT, and they can be volunteers. And when we have trainings, specific trainings, we'll send them to there. And if they can help in the region, also there is no problem for this. And for global person who want to help, I will add also, like Verena told, to help by funds or to integrate civil Lebanese civil defense or Lebanese Red Cross in Lebanon in their operation as the EMTs. So it can be helpful for us in this conflict and in other problems. Thank you.
Dr. Charles, can I ask you to put the detail? We've had a question about joining the LOPT. Would you mind putting some information into the chat for those people that are interested?
Yes, of course.
Yeah. And if you have any information about occupational therapy societies or other organizations that other professions might be able to join, pop that into, would be great. For us, did you have any burning things to add to that conversation about global support?
I think the advocacy could help. So advocacy about the shortage, advocacy about the needs can make a pressure, at least on the media around to support people working on the ground.
Great, thank you. Okay, so we're running short of time because we're having such a good discussion. So I'm going to ask you guys to keep your responses now very short. So for us, in a couple of minutes, can you please tell us how your team are prioritizing your caseloads in the face of overwhelming demand? Thank you.
Prioritizing is a little bit difficult, but it could be happened on a massive environment. So what we do, we put the physiotherapist. So now I'm answering regarding the rehabilitation itself.
Yes.
So when the physiotherapist be in the first consultation room, he can direct the patient to which service needed for him. In case there is a multiple trauma or a big case, he can ask him to go to the group of the physiotherapists assigned to the prolonged treatment plan. And if the case is a little bit simple, needs some advices, need only home program, there is another group on another room are assigned for giving more shorter plan of treatment in the clinic with a long home program advices. So when he go to that group of the physiotherapist, they know exactly this case is a little bit simple. He can do something at home with a very small support like distributing TheraBand, some elastic bandaging. So they learn him what to do and they ask him to return back after 3 weeks or 1 month because his case is very simple. So for the other group, they can take care of the patients with a multiple injury, with need several sessions per week, with a little bit minimizing, because we know a lot of cases are there. For the critical cases, they directed them to the inpatient department, which need hospitalized. It was always the bed occupancy rate above 100%, and some people in the corridors, but at least we provide the service inside the hospital for those patients in needs, with to be also decrease the workload. We shorten the assessment for documentation just to save time, to save effort. We make a special form of the assessment which used only in the emergencies, short assessment for burn cases, short assessment for trauma cases, and that help to give more time for the patients. That's and mainly what's happened on the ground. It was effective, but not give very good quality, to be honest. So when we come nowadays to a more calm situation on the context on the city, we take more time with the patients. We give more techniques, more interventions, with at least good time for the sessions.
Thank you. And I think that I mean, it's the biggest challenge of, it's what makes an emergency, isn't it? It's the overwhelming demand and not having enough to meet it. So I think that was really great insight into not just prioritizing patients, but also prioritizing treatment, which is often the missing step. I'm going to move ahead and come to Verena. If we could hear from you about considerations when organizing a rehabilitation team or service during conflict. And I'd like to add on a little question to that as well, around if you could provide some insight into the ideal shift length for your rehabilitation team members. That would be great. Thank you.
Sorry, I'm not quite sure of that add-on question, shift length.
We just had a question about, I think it was about how long do your staff work in for one shift? Yeah, and if you've made any modifications to that.
Okay, so I think generally when we set up a service in a conflict area, it is important, whether you come from inside or outside the country or the conflict area, that you always work within the law of the land. So it's not good for a non-professional to do a professional job. So it's quite important that we're quite clear on that. And I think even in emergencies, we need to be very adherent to that, because we should never forget that our highest priority should be first do no harm, even if there is a huge emergency and a big pressure on that. So I think we need to make sure that we have a workforce who is trained and capable of working with the cases they see. And this is not only clinical, but also to be able to work within conflict. We've heard quite telling tales from all of our participants who are in Gaza at the moment, or in Lebanon, and how they are under pressure. So the other very important thing is to not work in isolation and collaborate, because there is work for everybody. There is too much work, and the thing which we would want to avoid is doubling up. And doubling up can be avoided by liaising, linking, communicating with other organizations, with other providers, with the Ministry of Health. And WHO does a very good job with the rehab clusters, as we have seen in Gaza. And Amani, I really commend you again on the work you're doing. You're doing a fantastic job, you and the team around there. So we need to have trained and competent staff. We also need to be accountable for the work we're doing. So we are accountable not only to our employer and to the law, but we are also accountable to our beneficiaries or to our patients. And that goes into the advocacy role, which has also been widely talked about and which is very, very important. So part of that accountability is a minimum of data collection. That makes us accountable towards our beneficiaries, towards those who are giving us the funds to do the work. So for us, you talked a little bit about the triage system, how you had to cope. I think one of the things which is also important when you set up a service is to keep your staff as safe as possible, meaning the place you choose, to choose a place which is as safe as possible for the staff, but also for access to the patients. So the patients are actually able to access you and get you. And this is in some contexts, it is checkpoints which might hinder patients to go. There's all sorts of unsafe areas. So when you set up a service, make sure that you set it up in an area which is suitable for safety as much as possible. And then, as Firas said, support your staff. Be a team, care about each other, care about each other's well-being, not just about the patients, but also about each other. And I think that can be an addition, maybe I could say to what Firas said, is also to have a small group meeting in the morning to think about the scenarios which you might come across. So in last year, there was a time when we had daily catastrophic mass casualties, and we weren't sure they would come. We just didn't know when. So preparing the team for and preparing who is going where. I really like that system of changing the position to not expose individuals to the same kind of stressors every day. Sorry, that was a bit long.
Thank you very much. That was great. I think it's, really practical, a lot of communication, and I really liked your point about not working in isolation, and I think that's goes for pretty much everything we do in these environments. Thanks so much, and we're going to keep moving. I'm sorry that we're rushing a little bit now, but I do want to give some people the opportunity to finish their questions. So we're going to go to Fatima now. So we heard from Pete last week about displacement, and that displacement is a significant issue in most conflicts, and certainly is in the conflicts happening in the region at the moment. So we're wondering, do you have any advice on how we can provide effective services for people who are displaced?
Yeah, I mean, the first point in displacement, like we are not speaking only about injury. We are speaking about all people could have like any functional limitation and are like forced to be displaced. So we took big part on speaking about early rehabilitation, how much important to prioritize. Yes, we prioritize injury, but we need also to prioritize fairly. That means like people get displaced because that could be people non-communicable disease, or people having elderly status, or difficulties from multiple reasons, like congenital, all the rehab sectors, how to say, patient or people in need. So displacement like is a big issue in adding more barriers in the conflict to access to service. So starting by improving service sufficiency is like to have improving access. So making the service itself inclusive. So we cannot work an approach like standalone. In displacement, we have to work an integrated approach, taking the basic needs as mandatory part of it. Because like in rehabilitation, we speak about establishing field hospitals or establishing small units, but we cannot reach people in their places if we are stay in that unit. Also, we cannot also know all their needs or refer them if we are not in the community level. So we start by the need assessments. Like to talk like rehabilitation is a component with all the other need assessment, with all the basic needs should be ensured. Then we move to the prioritize fairly, like who are the people are most vulnerable, not from injury side, I mean could be also from chronic disease side. So we are not the only one. We should have improving the coordination between actors to ensure that displacement doesn't add any more barriers for people already has difficulties, especially people with disability, if I can highlight them. I mean, I took the opportunity because most people are even and during displacement, they are left behind during evacuation, during any safety measures. So displacement also breaks the continuity of care. So once we have people like are displaced, they don't have more access to their medication, to their services. And rehabilitation is one of the continuity of care when they have like a long medical condition. When you speak about kids with like child with cerebral palsy, so he break all his treatment plan. So it's very important to ensure the continuity of care. This is an advice why ensuring this continuity, not to speak about development, but having rehab everywhere, like ensuring improving the CBA component, like the inclusive community components, the networks, and that also need to have also well-trained professionals. And to resume all, to make any response inclusive, accessible, and integrated. This is how we can treat displacement, like to take it from the whole part as person-centered approach, but not only for rehab, a person-centered approach for all the person's need, and to ensure that all the main basic services are ensured or to advocate for it. So, and to keep in mind that displacement doesn't mean I change a house to another house. Displacement and conflict mean I change my condition, I change my lifestyle, I change my, I lost my function sometimes. I lost also my assistive device, as everything like behind it. I came only with a small blanket in a non-accessible area. If we look at Gaza or any conflict, unfortunately, in the region, was also health system destroyed because of conflict. So we need our when we build up like rehab service, is the service inclusive or not? Not about entry of the service, about reaching the people who are in need. Over to you. Thank you.
Thank you, Fatima. I think there's a whole body of work just on displacement that can be that could be done and how to support people who are displaced. And I think it's the next step, or the further development that we can do is really making sure that we're also meeting those needs as rehabilitation professionals. So thank you very much. I'm a little bit unsure. I know we're coming to the end of our time. I understand people may need to drop off. For the sake of the recording, if it's okay with the panelists, we might just finish our questions, but acknowledging that some of our participants may need to drop off, if that's okay with everyone. So I'll go to Amani. Amani, if you could talk to us about the fragmentation, and that's something that Charles and Faraz have also mentioned about the fragmentation of health services and also rehabilitation services. And they're often delivered by a range of actors, and we have representatives of those different actors on our panel, and different government departments. We're hoping that you can share with us some of the tips that you have developed and as observed in Gaza. And I believe, is this where you would like me to share your slide?
Erica, can you please share the
Yes.
interactive mapping pictures?
Yes.
Thank you, dear.
There we go.
So the picture, please, first. That's because it's not appear.
Oh, that's the only picture I have for you. I'm sorry. Oh,
Thank you so much.
the map?
Just
Yep.
yes. So very quickly, just to the time consuming and so on. One of the most common challenges in the conflict is the mapping of the key player and key actor of the services. So what we did as WHO and the health cluster, we again gather all the detailed data about all the key player in rehabilitation services across the Gaza Strip. You can see here in the map, we have 4 colors. Each colors appear to describe the level of rehabilitation: level 1 community based, level 2 PHC, level 3 as tertiary hospital, level 4 as specialized rehabilitation. When we click to any of those points, you can appear the location, the focal point, all the detail for each facility. And we make it a very massive training for all the K player and rehabilitation actor across all the Gaza Strip to use the services to clearly and interactive referral pathway for the patient. That's because I do a focus group with the number of the patient. I really surprised when I know 70% of the cases, they started the first rehabilitation session after 3 months of their injury. So this is delay of the rehabilitation services is really indicate the fragmented and the missing of the mapping. So we're taking lead to have this interactive mapping with the comprehensive data for all the rehabilitation actor across the Gaza Strip. Secondly, second picture, please, Erica. We have a deep understanding of
I
the
don't think,
distribution.
so I don't have another picture for you. I'm sorry, Amani.
Oh, okay, don't worry. I'll explain what we did. Also, we did a detailed deep analytic for the services distributed for the all the governorate in Gaza Strip to be ensured that we have equality and efficient rehabilitation services based on the number of the target population in each governorate. So we are ensured to no left no one behind, hatta even in the faraway area, and to be ensured that everyone is know where I can get the services at what level of the rehabilitation services. Last point from my side, and it's very, very, very important. We make a preparedness mobility aid kit. This is an emergency one. We put them in all the emergency room and all the mass casualty hospital to be ensured each cases once it's discharged from the emergency room to have the proper mobility aid from day one to again to support the cases, had to even go to the toilet and doing the activity daily life in the normal way. Last one, to left one behind in the conflict area, all the focus will go to trauma cases. But unfortunately, in Gaza, we have Guillain-Barre syndrome outbreak. So this is lesson learned us a lot to keep focusing for all the patient trauma, non-trauma, chronic disease, and acute one. Thank you so much. This is to remind me and you, as a humanitarian worker, to work transparently, hardly to at least to provide a high quality services for the service across all over the world. And thank you so much. Over to you, Erica.
Oh, thank you. And thank you. We love hearing your daughter in the background there. Thanks so much, Amani, and sorry for rushing you, but I think we're going to, is that map, Amani, is that map publicly available? It is, isn't it?
Yes, dear. I'll share the link.
That would be great, so people can have a bit of a look, because that map is really key to kind of understanding the picture for rehabilitation in Gaza at the moment. And because it can be updated regularly, I think it's a really good example of how you can reduce at least some of that fragmentation. We're almost at the end of our discussion today, but we just wanted to come back to Dr. Charles for your comments on what you think and how you've observed the role of the national professional societies in supporting rehabilitation in conflict zones.
I will make it shortly about it. I will say that they play a key role in coordinating rehabilitation services. They can train volunteers also, and they support local and international initiatives. In some cases, they can provide logistical and equipment also, and they can act also as a bridge between international NGOs and local communities, because we need to know that local and professional, they can have the trust of the population and the displaced people. We know it's something very, how to say, not risky, but very sensitive. So they can be the bridge with the international and local communities, and they can call in some cases some funds, international funds also.
Yeah, thank you. And just further on that, and I'll go to you first, Doctor, but if some of the other panelists would like to comment from your experience. I think quite a few of our participants in this call today are interested to understand how can they access professional support or mentorship to support them at this point in time. If any of you have any tips on that, or suggestions for how that can, you know, a mentorship arrangement could be put in place, please. But I'll go to you first, Dr. Shah.
I saw one question about someone who want to have the mentorship of professionals. I put my contacts to share this with the LOPT, that we can say, because our volunteers are Lebanese physical therapists integrated in the order of physical therapists. This is why we can't have not Lebanese physical therapists, but we can help and share also with other nationalities our experience, and to help them, mentoring them, maybe not on the ground with us, but we can make some discussion with them and mentoring them about many subjects.
Thank you. And Verena, please go ahead.
This is maybe not for the right for this point in time, but it is also a call for educational institutions to consider preparedness for disaster and conflict as part of their curriculum. And I think this would be the most useful for all of us, since we never know exactly where the next conflict or disaster is breaking out.
Thank you. Yeah, I completely agree. And I think that, you know, we're also fighting against that idea that it's an optional extra that can come later. But I think we're all realizing that whether it's a, you know, it's a conflict or some other kind of emergency, we never really know. Fatima, please go ahead.
I mean, to complete Verena point, I mean, last year when we had working in Haiti, one of our main activity was like to train and to include in the curriculum and of the medical services awareness about rehabilitation in emergency, because it was something like, unfortunately, when you have a country in conflict, the university are like getting low and low, like I mean getting less and less. The resources of professional rehabilitation are getting also very limited, so you don't have even the qualified people. When you have the qualified people, like sometimes like you don't have the knowledge about the service itself, because there is no more like who is raising that service. So we had a big work plan with with different university among the different governorate, like, or the departments that we are working in, to introduce at least the awareness component of rehabilitation or comprehensive rehabilitation in the curriculum of the main like medical or health sectors, including medicine, nursing, nursery as well, like for the pediatric one, all related to burn management from medical side, just to understand about rehabilitation, and also like a psycho social aspect. So it was one of like a main component in volatile environment, because like it was not known what is rehabilitation doing in, and it was also I will not say left behind, but just like country has a lot of priority to deal with. So even at education level, it was not recognized. So beside including the emergency rehab as model in like rehabilitation curriculum, the awareness itself for any multidisciplinary approach or multidisciplinary sector is important. Thank you.
Thank you. I'm going to wrap us up there because we're a little bit over time, and I know that it's getting into the evening. But before we do, I just wanted to acknowledge each of our panelists, acknowledge your time spent today and your energy in preparing for this, but also acknowledge the work that you're doing all the time, every day. And also, I would like to acknowledge all of you who are online, who are providing rehabilitation services in these environments in very challenging conditions. The humanitarian rehabilitation community is with you. We think about you often, and we're in awe of what you're still achieving, irrespective of all the challenges. So take care, stay safe, and we will see you all next week. I believe that the details for next week's session, which I believe is on spinal cord injuries, is in the chat. So please do join us. And like I said, this is the second of 10 webinars in this series. So there's plenty more to come. And we look forward to having you join us. Thank you and good night.
Thanks to you, Erika. Good night.
Good night.
Thank you.
It's our pleasure to meet you all. Thank you, Dil.